people may continue to filter in here, but I think we'll go ahead and get started. We're excited this week to have Dr. Milind Tambe here from Harvard University. He's the Gordon McKay Professor of Computer Science and the Director of the Center for Research on Computation in Society. And he's also the Principal Scientist and Director for AI for Social Good at Google Research. And he, of course, has many accolades, including having gotten his PhD from Carnegie Mellon. And he was also the recipient of the AAAI Award this year for Artificial Intelligence for the Benefit of Humanity. And as a part of that, gave a keynote at AAAI. And we're excited to have him here today, and I'll turn it over to him. Milind, thank you for being here.
Of course. Thank you. No, thank you for that nice introduction. Thank you all for being here, and thank you all for the people who are all on Zoom. It's always wonderful to be back on campus. So for over 15 years, my team and I have been focused on advancing AI and multi-agent systems for social impact, focusing on topics of public health, conservation, and public safety, with key challenge of how to optimize our limited intervention resources. So let me just jump right into the lessons we've learned. The first one is that social impact often leads to AI innovation, which in turn feeds further social impact. As a way of illustrating this lesson in terms of multi-agent resource allocation, taking examples from our previous work, let's look at public health. Here we have large populations to serve, but limited number of public health resources. So concrete example is work we have done with youth experiencing homelessness in Los Angeles. Harnessing the social networks of these youth, we are able to show that our influence maximization algorithms are far more effective in reducing HIV risk behaviors compared to traditional approaches. But this work required innovation in the area of influence maximization because the social networks are not given to us in advance. With respect to conservation, we have large conservation areas to protect limited number of ranger resources. Concrete example is work we have done in Uganda and Cambodia, where harnessing past poaching data, we are able to predict if poachers set traps or snares, and for the past several years have been able to remove thousands of these snares. This work requires innovation in the area of what we call green security games, which combines machine learning and game theory. With respect to public safety and security, we've contributed a new model called Stackelberg Security Games and contributed new algorithms that have been in use by security agencies in the United States, such as the Federal Air Marshals, the Coast Guard, and others. So if you've been on a US air carrier international flight, whether there was an air marshal or not, on your flight since 2009 may have been our algorithm that determined that. So second lesson here is that in AI for social impact, the entire data to deployment end-to-end pipeline is important. We begin our work by immersing ourselves in the domain, trying to understand the kind of data that a nonprofit or a government organization or regularly, usually our partners, have available. Following that, a predictive model makes predictions on which of the cases faced by this nonprofit are high risk or low risk. A prescriptive model then, because we cannot intervene on all of the cases, we have limited resources, tells us which cases to actually intervene on. And finally, field testing and deployment is important because this is AI for social impact. If you don't achieve social impact, it is not AI for social impact. You should notice also that this process is entirely partnership oriented from beginning to end, and also a use inspired approach. So with all that introduction, let me just jump right into what the agenda is for today. I'm very excited to share with you our recent work on maternal and child health with the world's two largest mobile health programs. One is called Mitra, is based in Mumbai. 200,000 mothers are registered at a time in this program. And the other is called Kilkari. This is a pan-India program. 3 million mothers are registered in this program at a time. I'll also talk about work on HIV prevention in Los Angeles. This is work out of Brian Wilder's thesis, who's a faculty member here. Some of you may be familiar with that work, so I'm going to touch on this very briefly. Also work on wildlife conservation in Uganda and Cambodia and Belize. This work was started by Fei Fang, who was a faculty member here 10 years ago in my research group. And again, some of you may be very familiar with it. So I'm going to just talk about the recent advances in this area. All of this has led, domain work has led to innovations in restless bandits, in decision-focused learning. I'll touch upon also work in influence maximization. And finally, just briefly touch on LLMs for public health. I wanted to thank all of my PhD students and postdocs. And so to thank them, I'll put up the picture of the lead PhD student on the top right-hand corner of the slide on which their work is shown. Also wanted to thank a key collaborator, Dr. Aparna Taneja at Google Research India, who's a co-author on several of the papers in the maternal and child health space. So let's begin with M-Mitra. So the motivation for this work is the UN Sustainable Development Goal that the maternal mortality ratio, mothers dying during childbirth or soon after, should be below 70 per 100,000 live births. So where we are today, Western Europe, the numbers are significantly lower than the UN target shown by the dashed line. United States, the numbers are increasing, but still below the UN target. If you look worldwide, the numbers are more than double what the UN target is. And so this may seem like a problem that belongs to the rest of the world, but if we look at even within the United States, as Michelle Williams, our former dean of the Harvard Chan School of Public Health, points out, for Black women in Mississippi, the mortality rate is 65.1 deaths per 100,000 live births, 20 times worse than women in Greece, Poland, or Slovenia. I mean, let alone Mississippi, even in Massachusetts, our local news reports that Massachusetts is failing its moms and babies. So this is an important problem of right here. It's not some problem out there. Today, though, I'm going to focus on challenges in maternal mortality rate in India, where the numbers are declining, but still higher than the UN target. We are very fortunate to be working with a nonprofit called Arman, which is active in 20 states in India, works with 41 million beneficiaries. We've been inspired by the founder of Arman, Dr. Aparna Hegde, who points out that pregnancy is not a disease, childhood is not an ailment, dying due to a natural life event is not acceptable. I met with Dr. Hegde at a Starbucks in Mumbai 5 years ago in the summer, and inspired by the important work that their organization does, decided to focus our research group's activities towards assisting them in the important work that they do. So in consultation with Arman, we decided to focus on this M-Mitra mobile health program that they have. This is a program for new and expecting mothers that harnesses the fact that mobile phones are now available everywhere in India. Everybody has them. And so this program, from the time the mother registers in the program to the baby being 1 year old, every week, the mother receives a 2-minute weekly automated health message. And so the message is something like this: for you and your baby to be strong, you need lots of iron. Iron-rich foods include meat, jaggery, and leafy green vegetables, and so on and so forth. This is a small snippet of the 2-minute message. The message is actually delivered in the local language, somewhat in a sing-song manner. And 2 million mothers have so far benefited from this program. So there's 141 messages that get delivered in this fashion. These are automated health messages. And in randomized control trials, Arman has shown that mothers who listen to these messages versus mothers who don't, there's a 30% increase in infant with triple birth weight at the end of the year. And there are other health benefits both to the mother and the baby. So where do we come in? Unfortunately, 30 to 40% of the mothers who register in the program stop listening, become low listeners, or drop out of the program. To understand why, Arman took us around to the different places where they register these mothers. They even took us to the homes of these beneficiaries. Now, I have grown up in the city of Mumbai. I know some of these neighborhoods, but going inside the homes of these beneficiaries was really eye-opening. 95% of the population, the families that Arman serves, their incomes are significantly below the international poverty line. So I got to see what that really means. And this clearly, there's a lot of pressure on these families and mothers, so they drop out of the program. So what can we do? Arman has this call center from where they can give calls to these mothers. So these are live service calls to try to persuade these mothers to not drop out of the program. But the call center is a small call center. They can only call a small fraction of the population. And the question becomes, which small fraction to call? So concretely, at a time, there are 200,000 mothers registered in the program. Every mother, every week, receives an automated health message. But from the call center, a live service call can only be given to 1,000 of these mothers. And the question is, which 1,000 should get this live service call so that we maximize the total number of health messages that are listened to? So to make this more concrete, consider this health worker who has 5 mothers under her care. 4 are shown in red. They have not listened to a health message. 1 shown in green has listened to a health message. So these are automated health messages that have gone out. 4 mothers have not listened to them. 1 has. Now, this health worker has to choose which 2 mothers I can make a live service call to this week. Supposing she chooses the first 2, this was a good choice. These 2 in red turn to green. There's 1 more mother who was in red who also turns to green. But now there's 2. Next week, she has to decide which 2 mothers to call now. Supposing, please go on.
Can I ask a quick question?
Please.
So, is there a reason that we think live calls would be more effective than just sending a reminder call, let's say an automated reminder call to anyone who hasn't listened?
Yes, so certainly texts, for example, have been sent and they are not as effective. And there's a lot of back and forth in these messages, in these calls. And sometimes it gets into more sensitive issues as well, like there's domestic abuse and so forth. So these live service calls are seen to be quite important in order to motivate these mothers to say, what's going on. So it's not like they just, it's not as though they call and then, just say, okay, please listen. It's much more a give and take.
Reminder.
Yeah, it's much more give and take and understanding why and explaining to them why it's important to listen and so on and so on. That's a good point. So now, you have to decide, okay, who do I call this week? Which 2 mothers are? Supposing these 2 who are shown in red are chosen. This, unfortunately, turns out to be a bad choice. The 2 who are shown in red don't turn to green. And in fact, those who are green also turn to red. The point being that there is a challenge in choosing the 1,000 beneficiaries. First, live calls may not change a beneficiary state, and beneficiaries may change state on their own. So how do you choose K out of N beneficiaries? We turn to restless bandits to choose K out of N. For those who may not be familiar, a restless bandit, each arm itself is a Markov decision problem. Each arm models 1 mother, 1 beneficiary. The mother might be in a bad state. She has not listened to an automated health message, or a good state. She has listened. We can intervene via service call on this mother, or we may not intervene. And then we have transition probabilities that represent the behaviors of these mothers. So if we intervene on the mother, the probability of going from a bad state to a good state may be 0.8. But if we don't intervene, the probability is 0.2. Now, in reality, of course, we have 200,000 of these mothers, so 200,000 MDPs, and we have to choose 1,000. This problem is known to be p-space hard. So one way that this problem gets solved is by computing a Whittle index. So Whittle index is defined as formally an infimum subsidy that can be offered to a passive action, a non-intervention action on a state, such that the Q value of the passive action becomes equal to the Q value of the active action, the intervention action. Informally, it's computing what's the benefit of intervening on this arm. So now we can rank all of the arms based on their Whittle indices and pull the top arms, the highest Whittle index arms. There's no out-of-the-box algorithm available to compute Whittle index, but fortunately, we had one created at AMAS 2016 that we were able to use. Unfortunately, we still don't know the transition probabilities of these mothers. So now here's where we can use past data from behaviors of the mothers. For each mother here, we have features, age, income, education, etc., and their behaviors for the past beneficiaries. The mother was in a bad state, got an intervention call, live service call, remained in a bad state, no intervention call, good state, etc. So from this, we can learn a model, a mapping from their features to transition probabilities. Next, we can do optimization to pick top K mothers using a Whittle index. We call this approach a 2-stage approach because first we maximize learning accuracy, and then separately we optimize by maximizing decision quality using the top K mothers. And now it's time to evaluate the system in the field. And so to that end, we ran this study with 23,000 mothers. This is the first large-scale application of these restless bandits for public health, as far as we know. These were divided into 3 groups. 1/3 in the restless bandit group, 1/3 in the round-robin group, and 1/3 in the current standard of care. Remember, each mother in each of these groups always got a health message every time. So there was no change in that. What changed is who got a service call. We called 225 mothers in the restless bandit group. These 225 each week were determined based on who had the top vital indices. So top 225 vital indices each week for 7 weeks got a service call. In the round robin group, it was the first 225, then the next 225, next 225, etc. Current standard of care, no service calls because that's the current standard of care. The question is, how many more health messages are listened to compared to the current standard of care in each of the groups? What we find here on the x-axis are the weeks, cumulatively y-axis, how many more health messages are listened to compared to the current standard of care. Blue is the restless bandit group, orange is the round robin group. We can see that with the round robin group, there's hardly any improvement over the current standard of care. With the restless bandit group, 600 more messages are listened to compared to the current standard of care. The point here is that it is important to optimize who gets service calls. If you just call people round robin, for example, there's hardly any improvement in their behaviors. We can show that the restless bandit cuts by 32% the drop-off rate over the current standard of care. Now, showing, interestingly, this whole, please.
Am I reading this graph correctly? So each week there are 225 calls made.
Yeah.
And that results in 100 additional messages per week being listened to.
Yes,
Is that about right?
yes, that's
Okay,
right.
so you gotta make 2 calls to get 1 more message listened to.
During this period, yes. And then, as you'll see in the next graph, the benefit of this will continue past. So it's not like they'll, once you sort of push them up in the listening state, the probability they'll stay in the listening state also increases. Or rather, you sort of push them into the listening state. And so now you also get benefits.
This is cumulative engagement, so it can't go down, right?
Right. No, what I mean is, supposing you stop calling at this point completely, you will still see the benefit of having made this call to this person beyond this week.
I see.
So there's, so it's not just here we've cut it off, but you'll see in the next graph, we don't cut off yet.
Question, the loss prevented means with respect to the.
Current standard of care. Yeah.
That's the baseline one here.
That's right. So the baseline is the current standard of care, and it's all compared to the current standard of care, what have you.
For example, before the current state was better than the round robin.
Yes.
So, in the picture you had with the restless bandit in the beginning, it
You mean-
looked like it's kind of where you had the graph with the states and the groups. You don't have to go back to that. but-
Yeah.
So it seems like this is like one state at a time. Well, couldn't there be like hysteresis? Like if I call you 7 times, that's when you start to do stuff. Or if I call you 7 times, that's when you're really tired of my calls and stop answering.
Yes, exactly right. So there can be more complex state representations. However, we are limited with the amount of data we have particularly about the interventions. And so this is a compromise. We have shown in other work that if we use a higher order Markov process, that we would get better accuracy, but we just are limited by the amount of data and also computational considerations. So we've chosen this for now. But yeah, I entirely agree that a detailed representation of states would be better. Yeah.
As graph, for week 1, there's advantage, week 2, there advantage. Is that after several weeks for the multi-arm bandit to converge, or this advantage shows directly at the first week?
So just to be clear, in this case, there's no online learning happening. So we've completely learned all the transition probabilities ahead of time. And now we're just running the model, just planning. There's no learning going on anymore. At least in this case, that's what it is. But it's a good point. of confusion. So there's no online learning happening right now.
Oh.
Cool. Thank you. Thank you for all these questions. Yeah, so establishing statistical significance of these resource allocation field trials is also an interesting open challenge. I was surprised to find, talking to our statistics department, that this is not a settled question. So what's the difference? In normal standard randomized control trial, there's a treatment group, everybody gets a treatment. A control group, nobody gets a treatment. Here, we are deciding on a policy as to who gets resources. That's the whole point of a resource allocation challenge. And who gets treated is based on who else is present, because we are ranking based on a Whittle index. So there's dependence amongst who gets treatment. And that creates problems for the independence assumptions. And so new estimators are needed to establish statistical significance. And that's been a set of papers that we've been pushing forward. But this is really a very interesting area for future work. So having done the first two-stage model, the next step was getting this new insight on machine learning and optimization because of this end-to-end deployment. So I've mentioned to you that first we did this two-stage model. First, machine learning to have accurate representation of behaviors. Following that, optimization to choose top-K beneficiaries. But maximizing learning accuracy doesn't translate into maximizing decision quality. And this was seen in a real example that we had. The orange data set from Arman has a higher predictive accuracy. Blue has a lower predictive accuracy. Therefore, we would have expected that orange would lead to improved listening behavior if we made calls based on the orange data set. But in reality, the result turned out to be exactly the opposite. Blue led to higher amount of listening. And so this led to the question, why might this happen? And so here's an example. So we have here some featured illustrative example y-axis is some transition probability. Blue are all low-risk mothers, they're larger in number. Red are all high-risk mothers, smaller in number. And if we say we do a two-stage model, we first maximize learning accuracy. A green regressor line here shows high learning accuracy, but it misses all the high-risk mothers, lower decision quality. If instead we use decision-focused learning to modify the loss function to directly maximize decision quality, then we learn this other green regressor line, which has higher decision quality, but lower learning accuracy. And so this is the approach that we are now using. And so instead of a two-stage model that takes gradients to improve MDP, learned transition probability accuracy, we're now looking at the downstream optimization problem, taking gradients from there, basically differentiating through the optimization problem. So Kai Wang's thesis was focused a lot on how to use decision-focused learning with sequential decision-making problems, differentiating through the sequential decision-making problem. And as part of that, he showed that this Whittle index is differentiable, which is what was needed. And so having established that, now it was time to test this decision-focused learning in the field. So now we took three arms. One, decision-focused learning, one was two-stage, and one was, again, current standard of care. If we looked at predictive accuracy, we find that the two-stage model has a high predictive accuracy predicting behavior. But if you look at the actual decision quality, we see here that with decision-focused learning, there's more listening going on, more actual decision behavior result compared to the two-stage model. And this goes back, Gretchen, to your point about the calls stop here, but you can see that the benefits continue to accrue. There is a bigger question about the sort of measuring the economic benefit of these calls, but it gets complicated, and that's not a study that we have yet done. So decision-focused learning is what we've now deployed with Restless Bandits with Arman. The system is called Saheli. Saheli means a friend in Hindi. It is also an acronym. This is just to tell you, we worked very hard to come up with a good acronym here. And we have served more than 330,000 beneficiaries since April 2022 when we deployed the system. 30% drop-offs have been prevented, as seen earlier as well. For bottom 25 percentile of listeners, the amount of listening that has gone on has been more than twice. What this means is more mothers are listening to taking iron and calcium and so on and so forth. So Neha Madiwala, who's the research director at Arman, points out that this AI model has been very effective in identifying women experiencing exceptional difficulties during pregnancy and prioritizing them for service calls. And this has been especially satisfying for the callers because then they can identify these women and guide them towards counseling services. So furthermore, we've also done a follow-on study to look at the health benefits of these higher listenership. There's a survey with 15 questions asking about things like, what are you doing for eating for your health after delivery? Looking at knowledge for taking care of themselves and the baby after delivery. And we found that higher listenership had led to higher improved health behaviors. So this is an initial study, a workshop paper, a follow-on larger study is in progress. And all of this has led Dr. Hegde to say that we are able to, in this video, AI for Social Good in partnership with Arman on YouTube, you could look up if you have interest. We're able to reach out to more and more women each week and get them back into the fold and save lives because of AI. I'm going to now play a video of a mother from the same YouTube video talking to us about the benefit of this AI intervention.
तो फोन होते ऐकत पहिला त्याच्यानंतर मग त्या ताईचा कॉल आला त्या घरी आल्या मला समजलं हा कॉल घ्यायला पाहिजे तुझ्या पोरांसाठी चांगला आहे का मग तेव्हा मी कॉल घ्यायला लागले ते कॉल ऐकून खूप बरं वाटतं की कोणीतरी घरचाच मला कोणीतरी समजावायला येतंय मग जसं ते कॉल ऐकते मी तसंच मी माझ्या पोरीचं संगोपन करते.
So this is a mother speaking in Marathi, which is my mother tongue. And she's in Mumbai. So there's a little extra satisfaction that somebody in Mumbai speaking Marathi is benefiting from our research. But one of the other benefits of this work in AI for social impact is all the new research challenges that come out. So I'm going to talk about 3 research directions. The first is new approaches for choosing the top K policies in restless bandits. The second is generalizing this model to other health challenges. And finally, further generalization using LLMs and a pre-trained restless bandit. So with respect to choosing these top K RMAP actions, so far we've discussed this decision-focused learning where we change the loss function to directly maximize decision quality, but it differentiates through the optimization problem. So in Sanket Shah's PhD work, he's saying, could we directly learn convex decision loss and essentially get rid of this differentiation through the optimization problem? So we don't have to handcraft this differentiable surrogate optimization problems. The other problem is this online learning, which we referenced earlier. So we've been working on different online learning algorithms, in some sense, this personalizing care towards individual mothers. I'll highlight one from AAAI 23 called UC Whittle, upper confidence bound Whittle, similar to upper confidence bound and stochastic bandits that you may be familiar with. So first step here, we compute confidence bounds on transition probabilities of each arm. However, higher transition probability doesn't mean higher Whittle index. So from this, there's an optimization problem solved to compute optimistic transition probabilities. These optimistic transition probabilities are used to compute optimistic Whittle indices, which are for higher Whittle indices. And then you pull the arms with a higher Whittle index and continue. So because it's this restless bandit, we can't quite use UCB as is. We have to use this additional step. And it provides a frequentist regret. A third direction has been to provide, instead of pinpoint probability estimates, provide some kind of interval uncertainty over each arm's transition probability. And now the question becomes, how do you find a more robust top K policy? So we do this by doing this minimizing maximum regret by playing a zero-sum game against nature, where we are trying to come up with a policy that improves our reward, but nature is trying to choose transition probabilities to cause our algorithm to perform as worse as possible. So this is a game where, on the one hand, we generate all kinds of Whittle index policies along the rows as a row player. Nature is trying to choose individual transition probabilities to cause these policies to perform as worse as possible. This becomes a very large-scale game and gets solved with this double oracle approach, which I'm not going to have time to go into. But in simulation, at least the robust approach reduces regret compared to the original approach. So all of these things would need to get tried actually in the field before anything like deployment. There are also other health challenges, we can generalize this approach to. One of them is tuberculosis, which kills 1.3 million people worldwide. The treatment for tuberculosis is for the patients to take their pills for 6 months. I get tired if a doctor tells me to do something for 6 days. 6 months is a very long time, and patients drop off of treatment, which is bad for them, but it also leads to drug-resistant bacteria. So governments try to remind patients to take their medicine. So you can imagine it's a similar problem where there's a call center from where these health workers call patients to remind them to take their TB medicine. Unfortunately, the caller doesn't know the state of the patient in this case. Have they taken their medicine or not? So a single caller has hundreds of patients under her care and has to choose a few that she could call today. Supposing she calls the first 3, 2 of them, shown in red, have not taken their medicine. 1 of them has. Now she has to decide tomorrow, who do I call? And this goes on, and you can imagine that this is very similar to the problem we've seen earlier with maternal and child health, except the state of the arm is not known. This is a challenge of partial observability or POMDP. So each arm here is a POMDP, but it's a special kind of a POMDP. If you call the patient, the state of uncertainty collapses. We know the exact state. So now we define a model called collapsing restless bandage and use that to solve this problem quickly. Another application area is diabetes, which unfortunately affects 540 million people worldwide. There are now these digital health adherence programs, log exercises and blood sugar and so forth. But again, patients may drop off of treatment. And so then there's a question of, you have health coaches, who should they call or text next? And so this is again a challenge for restless bandage. In our JMIR diabetes paper this year, we show that the use of equitable RMAPs to ensure that we can allocate coaches to right kinds of patients. But the goal here was to distribute resources across arms to avoid any disparities between groups. So we looked at max min and max NASH welfare as 2 possible objectives. So far I have talked to you about creating special restless bandage for each different disease and us putting in the right kinds of objectives for each of these restless bandage models and so on. What we want to really go towards is instructable, pre-trained restless bandage so that nonprofits around the world or government organizations or whoever else can use these models more easily. So goal is a pre-trained, instructable, multi-action restless bandage. Let me break that down. Instructable meaning that the nonprofit should be able to give tasks or change objectives of these restless bandage without us being involved. We want it to be beyond binary action. So binary action means either we intervene or don't intervene. But you can imagine that even on a single beneficiary, there can be multiple interventions, not just call, but maybe we can send a doctor to their home, or we can text them. So there can be multiple interventions per arm. Once you go to multi-action, RMAP Whittle index no longer works. So the state of the art is this RL approach called DDLPO. But this approach is not usable, 0 shot. If new arms come in, if patients drop out, new patients join. If you go to a new population, this cannot be used 0 shot. So we want a 0 shot approach with a pre-trained model so that when faced with the new patients or drop out or drop in, that we can apply this model. So our first step was to build this pre-trained model. And so generally in multi-agent RL systems, the sample complexity grows exponentially with the number of agents. However, with the restless bandage, with these N arms, if you use this Lagrangian relaxation and feature-based Q values, then we can actually benefit from generalization across arms. The arms can cooperate with each other. So using this Lagrangian relaxation to compute policies, B is the budget, a fixed lambda, then the Q values of all of the arms become independent. The Q values are based on the features of these arms, like age, income, education, etc. What this means is that mothers who have similar features now, these arms can learn from each other. And we can show that the generalization error drops with the larger number of arms. In simulation, purely, we have seen that in different domains that this kind of an approach shows promise. So The orange, the golden bar in the middle is our pre-trained model. Black is DDLPO. So given a new data set, DDLPO had to be trained from scratch. The golden bar was first trained on a different data set and then at test time presented with this new set of arms, new set of beneficiaries. And it is able to reach the performance of this DDLPO. And when patients drop out, DDLPO cannot function, but this pre-trained model can continue to function. So this is all still simulations, but it's showing promise. The next step then is, can we give it tasks using an LLM? And so this is the next step that we've taken. So supposing Arman wants to say, prioritize low-income mothers. So you can imagine there's a language command given proper code-based context. The LLM here will generate candidate reward functions for these different arms. And then prefer map, given these reward functions, will generate generates policies. We simulate those and then summarize the policy outcomes back to the LLM in terms of what is the distribution of people in terms of their age, income, etc. And this LLM reflection then allows the LLM in the next iteration to generate a new set of rewards. And in this way now we can allow an NGO to start giving new commands in natural language to allow the model to change the reward function and come up with different policies. So for example, we may say, give more attention to beneficiaries who likely work early in the morning and late at night. There is no direct feature like that in the data set, but we can see that the LLM then generates these policies. So here we have shown this human. So this is a reward function generated by a human, which was not made accessible to the LLM ahead of time. And upon reflection, you can see that it starts to reach the human level behavior in terms of policy outcomes. In terms of, if you make the command more complex, it has to combine more features. Advantage those who prefer being called between 12:30 and 3:30 and registered as an NGO. Upon zero shot, which is shown in brown, performance is low. And with the reflection, performance starts to increase, but still in this case now, it's harder to get to human level. In our paper, we have a dozen such examples showing some where it is harder to get to human level, and some extreme cases where if the command is sufficiently ambiguous, the LLM just has a really hard time. So this is just a way to show that there's very exciting next steps that could be taken in this space to allow other organizations around the world to potentially benefit from this type of technique. I want to switch now and briefly talk about the next step that we're taking. Hi.
So do you consider like when to call? Is that a variable that you choose?
When to call, there's two when to calls here. One is the automated health message, when is it to be sent? And then there is when to do the service calls. In this example, I'm going to show you next. There is no information available to us about when to do the automated health message. In the previous example, the NGO, when they register a mother, they ask her, when should a health message be sent to you?
You see like the benefits of this type of procedure as targeting more people who are more likely to receive calls, or when you are targeting people who are more amenable to change once they receive the call.
Sorry, I couldn't completely understand your question. Sorry, could you?
So like you see the benefits as more coming mostly from people who are more likely to receive the calls in the first place, or you're mostly more in terms of targeting people who are more amenable to changes, traditional or then receive.
I guess so. So you're saying, I guess we have no knowledge, right, ahead of time of who's amenable to change based on service calls. That's what you're asking, right? I mean, who's amenable to change in behavior due to a service call or not? And we have no knowledge of that ahead of time. The surveys that we've done of these populations have generally told us that why did you change your behavior based on the service call? And 70% or more have generally said they got more motivation from the service call. So it's they didn't understand why was it important to listen to this information. And so by engaging in this conversation with the call center worker, they got more motivation to continue listening. And then remaining 30% or so is all that you're calling us in the wrong language for the health messages, or you're calling us at the wrong time, things of that nature, or change my phone number. And those tend to be kind of less. So that's the way things have been. So I would say that the motivation itself is like a key thing that these service calls provide.
How do you get the covariant information about the callers,
The-
for the recipients?
The age, income, and all of that. Yes, that is the NGO collects all of that when
So
there
it's
is.
not like a actual survey, it's when they register somebody.
That's right.
And then is their IT system sophisticated enough to, you don't have to worry about that as researchers, like they just already have a good one, or is it?
Yes, the IT system, all of that. So all of the infrastructure they have of calling these sending out these automated services, everything. So we've just sort of, they have a call center too. They just didn't know who to call. And that's where.
Yeah, I've worked at NGOs where there's just really pitiful amount of IT. It's just like, really ad hoc, and that's nice that in this case, the whole thing data wise is pretty set up for you.
Yes. I mean, they're a very large scale organization, so yeah.
Being in India helps. So it seems like there's a lot of expertise in all the data aspects of an NGO where a lot of places might not have that.
Yes. So the covariant will become important here. So the next thing I wanted to discuss is the Skilkari program, which is the largest mobile health program for maternal and child health in the world. And this is run by India's Ministry of Health and Family Welfare. 30 million beneficiaries have gone through this program and benefited from it. At any one time, 3 million mothers are registered. And this number is growing. And Arman is trying to help the government scale this up. And we are trying to help Arman to prevent drop off from this service. So the program is very similar to the Mitra program, messages going out, except this is not local to Mumbai. This is India-wide program. And to understand that, I've gone to different places in India, trying to understand how this program operates in different parts of India. And key challenges compared to this Mitra program. First, the government will not release any demographic features to us in this case. That's it. And furthermore, they don't collect the time preference for when health messages need to be sent out to these beneficiaries. So then these are the two challenges that we have to face. So with respect to the fact that there's no demographic features, now we use time series to make predictions about future listening. So for a particular mother, supposing in week 1, she has listened to 40 seconds, week 2, 60 seconds, week 3, 10 seconds. Now we can predict her listening for the 4th week. So this is basically using this time series. And now to select top K arms, we've defined a simpler index called time series arm ranking index rather than the Whittle index. And so it's a ratio. What is the benefit of calling this mother in terms of increased listening compared to if we don't intervene, what would be the listenership? That's VN. If we intervene, what would be the listenership? That's UN, and use that ratio to determine a rank and then call the mothers to the top rank. So in this case, we've only been able to do simulations so far. So with 4,000 beneficiary data from the state of Odisha in India, we are able to show here, if we use this TARI index, this time series arm ranking index, to intervene on 1% of these beneficiaries every week, then it leads to higher listenership rather than intervening them on random. So this is one intervention, one AI application we want to apply here. The second is what Faye, you had asked, when to deliver an automated health message to a mother. This information is not available to us. So there's no time slot preference, and often this is a shared phone, so between a family, so the mother doesn't have access to the phone all the time. So now the current approach the government has is to make 9 phone calls at random times to trying to get the call to be picked up. If instead we can use a bandit approach, that can lead to improved listenership. So standard stochastic bandit, a UCB style algorithm, leads to improve learning of what is a favored time slot for a mother, preferred time slot for this mother to listen to this call. So on the x-axis here are mothers with different rates of engagement. And on the y-axis is how many retries were required before a call was picked up. And this is from the real data in the state of Odisha. And so random is what is tried now. If we use UCB to learn the mother's preferences, then in simulation, we can show that it already reduces the number of retries required to reach this mother. However, if we now use a collaborative bandits approach using their latent features to select which mother when to call, then it leads to an even faster time slot selection. And that's the green bar that is shown here, leads to even fewer retries. And so this is our AMAS 24 paper that tries to use these collaborative bandits. So this is all currently in simulation. We are very excited to take the next steps to actually test this out in the field with the Skillkari program. And so that's one of the directions. In terms of other directions, we've worked with other NGOs, for example, Help Mom in Nigeria. So our Ichkai 22 paper presented a model AI-driven vaccination intervention. In AAAI 24, we were thrilled to find that Help Mom has taken this model, we were not involved in this, and deployed it in Nigeria in the Oyo district with 13,000 of these mothers and shown that they have improved the vaccination rates. But beyond that, we are now going to start work with our Massachusetts Department of Population Health for maternal and child health, because this is a priority for our government. And also collaboration with this Harvard Medical School for maternal and child health in Rwanda. So those are our two next steps. So this ends the first section of my presentation. As I mentioned, the other two sections are short. Key takeaways from here are that social impact leads to innovations here in restless bandits and decision-focused learning. So hopefully I've shown you that social impact and AI innovation go hand in hand. This whole end-to-end pipeline, this data to deployment analysis is important because, for example, it revealed the importance of decision-focused learning. And that restless bandits themselves are a useful tool for public health and resource allocation. And hopefully a future work of instructable general purpose restless bandits would make them available to many organizations worldwide. I know it's 4 o'clock. I have a couple more smaller sections to go through. Should I go on or?
Yeah, you're good. I mean,
Okay.
It's only 3:50 right now. So.
All right. So the other parts are shorter parts, and some of you may be familiar with those because those are taken from the thesis of people who are faculty members here. The first one is HIV prevention, which is preventing HIV in youth experiencing homelessness. There's 6,000 youth who sleep on the streets in Los Angeles every night. Actually, recent reports say the numbers have grown to 9,000 youth. And so the rates of HIV in this population are 10 times the rates of the normal house population. Now, you can't reach every one of these youth to educate them about HIV prevention. So instead, homeless shelters use this idea of influence maximization. So they'll call peer leaders, educate them about HIV prevention, expect them to talk to their friends and their friends to talk to their friends, and information to spread in this real life social network. This is not happening electronically. So now, to make this concrete, here's the actual homeless youth network. Each number here is a youth. Each edge is a friendship edge between two youth. And we're trying to choose key influencers to maximize expected number of influence nodes. This is a photograph from an actual education session happening where our social work colleague is educating these youth. We modeled the information spread via this independent cascade model. So if youth C is educated about HIV prevention, their friend D will get educated with a probability of 0.4. If D is educated, their friend E will get educated with a probability of 0.4. Taking standard algorithms for influence maximization in the literature, applying this to our context, led to several challenges. First, there's uncertainty in propagation probabilities. I said 0.4, but we do not know these probabilities exactly. we have to rely on a multi-step dynamic policies. Traditionally, you could call key influencers and all of them would show up in the homeless youth setting. You call these youth, one of them on their way may get arrested. They may not show up. One of them may choose to run away and send their friend instead. So the youth we get for spreading influence are not the youth we called. And so now we have a multi-step dynamic policies to keep compensating for who actually showed up. And finally, the social network itself is not known in advance. We can do a limited set of queries to try to uncover the network. So this sort of sampling is also crucial. I'm not going to have time to go through all of these, but just focusing on the last one here, you can imagine that we don't know the social network, so send your social work colleague to a homeless shelter and ask them to interview each and every one of these homeless youth, ask them who their friends are, map out the whole network. This is time consuming, and if you wanted to use this program in other cities, it's not going to work. So instead, if you can sample a small fraction, let's say 15% of these youth, and ask them who are your top 5 friends or something like that, and then use that to determine who are the key influencers, that is a much better strategy, much more usable across different places. So the idea is we want to query 15% of the population and then output from this K peer leader nodes such that the influence spread by this group is same as what we would accomplish had we known the entire social network in advance. So this is part of Brian Wilder's thesis. He presented several algorithms to that end. One of them was the sample nodes randomly and estimate sizes of the communities those nodes belong to, and then choose seeds from the largest K communities. So he has some formal guarantees for the performance of these algorithms. I'm going to turn to the experiment we ran. The system was called Change. First part of it is network sampling. So following that, a robust multi-step policy, and then finally peer leader selection. So we ran a study with 750 youth, 250 in the change arm, which is peer leaders are selected using our policy, 250 in degree centrality. Peer leaders are selected as the most popular youth. This is the normal policy used by the homeless shelters. And 250 are in control group, no intervention at all. And now we want to know at the end of 1 month and at the end of 3 months, is there an actual reduction in HIV risk behaviors? And this is work done with 3 homeless shelters, My Friend's Place, Los Angeles LGBT Center, and Safe Place for Youth. And as far as we know, again, the first large-scale application of this influence maximization for public health. And at the end of 1 month, what we find is that in terms of this HIV risk behavior of reduction in condomless anal sex, with change, there's more than 30% reduction, but with degree centrality and control, there is no reduction at the end of 1 month. At the end of 3 months, degree centrality begins to catch up, but still change is superior. The point here is that having change make these reductions faster is important because this is a HIV risk behavior, and also because it's a community where people come and go, and therefore having this reduction happen faster is important. We have also looked at reduction in condomless vaginal sex, and again, we can see that change is superior. This is what our colleague,
to kind of like marry this tech world with this social service world, like, and how we can kind of go deeper and impact young people and elevate them.
So some of the directions for future work here are fairness and influence maximization and using RL to improve the speed at which these algorithms work. Key takeaway from this section, lack of data is frequent in AI for social impact, and that in itself sometimes becomes the PhD thesis. So handling this lack of data must be a key part of this research strategy. I'll take a few quick minutes to talk about wildlife conservation. This was work started by Fei Fang here 10 years ago in our research group. I just wanted to give you a quick update on this work. So in national parks around the globe, there's wonderful wildlife, but there's threats to these wildlife, traps or snares that are placed in these parks. And rangers have to go look for these snares. There's 20,000 snares placed in these parks annually. There's 200 rangers that search for these 20,000 snares, like in Murchison Falls. And you can imagine this is a difficult task to try to find these snares. how can we help these rangers? So we built a system called PAUSE. So it divides up the park into 1 kilometer by 1 kilometer grid square. And then the machine learning system makes predictions on what are the hotspots. And then a game theoretic component tries to prescribe where to patrol. So I'm going to just quickly talk to you about recent results in this space. So in terms of making predictions, we have past data on range of patrol frequency in grid square, animal density. We have other data, distance to rivers, roads, and villages. We're trying to predict the probability of finding a snare per 1 kilometer grid square. So we've built such a predictive model. And then based on this model, we can provide predictions to rangers to go look for these kinds of snares. So in Cambodia, for example, the number of snares found per month jumped fivefold after deployment of PAUSE. In 2021, there's 1,000 snares found in March alone due to PAUSE. And you can see that in areas that were not patrolled as much, for example, in this northeast corner of Shripok Wildlife Sanctuary, we find that with PAUSE, we asked rangers to go in this area, and they were able to find these elephant snares and remove them. So we've done a longer study in 3 national parks, Queen Elizabeth, Mochizu Falls, and Shripok Wildlife Sanctuary. And here we selected 24 areas which were infrequently patrolled. And PAUSE predicted in some of them to be high risk, more snares would be found. Some of them would be low risk, less snares would be found. Then we asked rangers to go patrol that for 6 months. And where we predicted high risk, indeed more snares were found. Where we predicted low risk, less snares were found. Following that, there's a game theoretic component using security games. I have come and given seminars at CMU on security games many times, so I'm going to skip this section altogether. This PAUSE has been integrated with the SMART platform. SMART is this collaboration of many different conservation agencies. And so what this means is now SMART is what rangers around the world use to collect data on poaching. So what this means now is that PAUSE is available to rangers around the globe to try to predict where poaching threats are. And so we are very glad that this system is now available to these rangers to try to find these snares. And the software integration is still in progress, but we're already seeing these sort of benefits accrue. There are lots of challenges due to lack of data in terms of bandits. I'll just point to one and then I'll move to my lessons learned. So this is recent work on trying to find rhinos. The problem is with finding rhinos is elusive. So how do you find rhinos? So our ecology friends told us that if you can find rhino middens, that is communal defecation sites. So find rhino latrines, and then you'll find the rhinos. So what this means is all of recent drones and AI is being used to find rhino poop. And if we can find that, we can find the rhinos. So there's a lot more to cover. We've been engaged with this causal inference and poaching deterrence and so on and so forth. Lily Xu is the leader of this project, and she's been going around the world to different parks to talk to them about using PAUSE to learn challenges and so forth. So I'll end here by some key lessons. So first, achieving social impact and AI innovation go hand in hand. This whole data to deployment end-to-end perspective is important in AI for social impact. Lack of data is the norm, and often it should be part of the project strategy. Partnerships with nonprofits, governments, and local communities is crucial. It's important to integrate AI innovations in the normal workflow of an NGO or a government. We don't want to engage in helicopter science. We don't want to go to an NGO, take their data, publish a paper critical of what they've been doing and run away. We want to have long-term engagements. And it's important to step out of the lab into the field and embrace interdisciplinary research. Now, we are in Newell Simon Hall, and I thought I could summarize a lot of what I'm saying here, or all of what I'm saying here in terms of what Newell said. So this is his last lecture on desires and divergence. For any students here who haven't listened to that lecture, I highly recommend listening to that lecture. So at the very end of the lecture, he talks about listen to nature. And so my version of that listen to nature is listen to the social impact. And so that's where I'll end my talk. So thank you all for sticking here. It's late on Friday. Thank you for still being here. And if you wanted to get in touch with me, that's my contact information. Thank you.